This
record
conference will now be recorded.
We'll record your question and answer sessions through the chat box. So if you have any questions through the presentation, please log them on the chat box. We'll record them, and we will answer questions following the presentation. When you enter your chat, when you chat your questions, select the option Chat to Everyone so that we could use your questions as a training opportunity for all the callers. Thank you. So today's topic will cover the near-miss report for ICD-10 coding, which will identify potential risk adjustment opportunities.
Okay, but I can't hear her.
I was just hearing her.
Right. Then I can't do it. Then I can't do it. Yeah, then I can't do it. Because he wanted me to mute all of them. When I do that, I mute her too.
Don't.
Right.
Leave them open.
Okay.
Okay, so let's begin. So for 2019 HCC updates, there are major changes for the CMS 2019 risk adjustment model, including the addition of 4 new risk-generating HCCs in the chronic condition categories related to substance abuse, mental health, and severity of chronic kidney disease, stage 3. A reminder through the HCC model is that this predicts the estimated future costs for individual patients. The CMS model is prospective, meaning the data collected in the base year is determined for the expected costs for the following year, which is the predicted year. So the data submitted in 2018, which is the base year, is used to predict the expense in 2019, which is the predicted year. The HCC model is concurrent, meaning the model predicts future expenditures associated with the current year's health event. So the 4 new HCC categories include HCC 56, drug abuse, uncomplicated except cannabis, reactive and unspecified psychosis, HCC 58, HCC 60, personality disorders, and HCC 138, chronic kidney disease, moderate, stage 3. So before I begin the near-miss report, I want to touch briefly on the ICD-10 code structure, as this will directly affect how we're documenting and coding and identifying ICD-10 codes missing within the near-miss file category. The ICD-10 has a code structure. You'll notice that there are alphas at the end of each of your ICD-10 codes. There's the letter A, D, and S. So the letter A identifies that the ICD-10 code is an initial encounter. This describes the entire period in which a patient is receiving active treatment for an injury, poisoning, or other consequences of an external cause. An example of an initial encounter would be example code ICD-10 code T82855A, stenosis of the coronary artery disease. This does not risk adjust in this particular category, and we'll talk about that as we go through the near-miss report. The second example of the ICD-10 code structure is a subsequent encounter. There are ICD-10 codes listed as subsequent. This describes any encounter after the active phase of treatment when the patient is receiving routine care for the injury during the period of healing or recovery. An example of this is diagnosis code M48.50XD. The code also will not risk adjust, and we'll discuss that option in the near-miss file category. The third example is the alpha S, sequela. It's the 7th character extension, S, indicates that it's complication or condition that arises as a direct result of an injury. So as you're coding in your EMR systems, are populating your ICD-10 code file, you should notice the alphas at the end, the A, the D, the F, and how you're using them when you're documenting conditions related to HCC. So attached is the near-miss report. Brand New Day uses the near-miss report to identify potential ICD-10 codes that should risk adjust as a part of the HCC model calculation. So we use this report or file by data mining. We take in your encounter data files, we take in claims from specialty files, we use pharmacy data, and we use other criteria related to the patient to identify suspected ICD-10 codes which were potentially missed during the initial submission of the encounters. So you'll notice here on the ICD-10 codes build, so this is real data that we've extracted from the Brand New Day system for various providers submitting ICD-10 codes either through claims or encounter data. As we notice on these examples, the codes that were submitted to Brand New Day did not risk adjust on the model. The codes that will risk adjust, we've crosswalked them to what we believe to be a risk adjustable service based upon other criteria that we were able to locate through data mining through the members' patient charts. This report presents all of the valid diagnoses codes that will not pay, but after reviewing the charts, we've identified that those conditions were either did not have the specificity needed to map to an HCC, or in some cases they were too specific and did not map to an appropriate HCC, as you can see in the mapping that's on this report. Another example of the coding that we've identified is we have examples here where we've identified atherosclerosis condition and other coronary conditions that did not risk adjust or map to the code that was billed in the category, but we were able to look at other conditions and other criteria to identify if the patients would have met that criteria. So in this case, what we've done is identified other treatment plans or other plan identifiers to help us with mapping that risk adjustment ICD-10 code. So in the case of atherosclerosis heart disease, a provider submitted an ICD-10 code listed here, and after reviewing the data, we asked questions such as, is the member on nitroglycerin? So is there some sort of medication or pharmacy or treatment that would better describe or be more specific to the condition where we're able to map it to a category that would risk adjust on the HCC code model? So on the HCC code model, I'm going to slide over a chart. Can you see that chart, Vanessa? Okay. So on the HCC code model, what we've done is we've taken all of the ICD-10 codes, we've looked at the HCC code categories, and we've used clinical data to identify disease interactions, medications, pharmacy, and data mining to identify the appropriate ICD codes to better map and risk adjust our data. So we are currently distributing near-miss reports based on specific encounter data from PCP providers and specialists to identify potential gaps in care or potential coding that we could build to the greatest degree of specificity in order to map to capture the HCC code category. Another example of where we find frequently missed opportunities would be in the category of morbid obesity. For morbid obesity, it's defined as being 100 pounds or more above the ideal body weight, having a BMI of 40 or greater, or having a BMI of 35 or greater, and one or more comorbid conditions. So for example, if I go back to my near-miss report, I'm able to see that all of these conditions here, the E66 code ranges, are other unspecified conditions related to morbid obesity. And all of these members generally will fall into a BMI category of 40 or above. However, we have a category of members who have BMIs that are 35. Within the BMI 35 range, we are looking for additional conditions. So if I report a code Z68 through Z68.29 and E66.01, it's morbid severe obesity due to excess calories. If my BMI is greater than 35 through 39 with the related comorbidities such as diabetes, hypertension, COPD, with supporting documentation of the condition, I should bill an ICD-10 code E66.01 to classify my patient with a BMI of 35 and those comorbid conditions of diabetes and hypertension. I am able to code now my E6601 to capture the HCC code for morbid obesity. So here in this box, this is an example of the near-miss reporting. You'll see that the Z6835 code is the body mass index code that tells me my patient is between 35 and 39 on the HCC code model. Now this code will not risk adjust as a standalone, but as I go through my patient's medical record and charting, I'm looking to see that I now have a patient whose BMI is greater than 35. They're seen with comorbidity conditions such as arthritis, there's other sleep apnea, diabetic conditions, coronary artery diseases. I can code all of that information and map it to an E66.01 to maximize my revenue on the HCC code category for morbid obesity. Just as a side note, that we want to keep in mind that the BMI codes themselves are not intended to be used as standalone codes. They were always meant to be accompanied by a corresponding diagnosis code. So as you go through your diagnoses of BMI, we want to ensure that we have a corresponding condition related to the BMI code related to morbid obesity. So the near-miss report is currently being distributed amongst providers through our JLUMC packets, also posted on the SFTP site. So if you have any questions regarding the near-miss report, our provider service team is available to take your questions, and we'll walk you through the reports if we need individual training related to these reports and how to better maximize on the diagnoses and captures through HCC. So we're now going to switch over to the diabetic category. If there were any questions related to the near-miss report, please document them in the chat box, and we'll review the question and answer the question at the end of the presentation. So diabetes. What is diabetes? Diabetes is a condition in which the body does not properly process the food used for energy. Most of the food we eat turns into glucose or sugar for our bodies to use as energy. The glucose gets into the cells of the body. When you have diabetes, your body doesn't make enough insulin, or you can't use its own insulin as well as it should, and this causes sugar buildup in the blood. So most of our offices, we see a lot of conditions related to diabetes. There's a lot of ICD-10 codes that come in through our data mining that are listed as unspecified. We see acute conditions when we think there should be a chronic diagnosis, or vice versa, we'll see chronic where the patient should be diagnosed as acute. In the HCC model for diabetes, there's a disease hierarchy. So some HCCs will override others so that if a patient has more than one HCC within a category, we're only paid on one HCC. The way that works is the acute complicated, so the lowest number, you'll see here HCC code 17, HCC code 18, and HCC code 19. The lowest number in those categories would present the highest RAF score. So if I have a 17, it's better than 18. If I have an 18, it's better than 19. So I'm looking at acute complications in 17. My chronic complication and diseases such as neuropathy, eyes, renal would present an HCC code at 18. And my unspecified conditions or diabetes without complications would present an HCC code 19. We want to be as specific as possible when diagnoses and our conditions and comorbidities associated with diabetes so that we maximize on the complete RAF that's available to our offices by using the correct ICD-10 codes related to diabetes. So as you see in this example, we're showing a slide of the RAF score for diabetes, those diagnosis codes that are not specific, and those diagnosis codes which are more specific to the condition of diabetes. So if I look at the first example highlighted in yellow, E11.61, this is type 2 diabetes, and it has no RAF score when using this code. The reason it has no RAF score is because it's not billed to the greatest degree of specificity. The 2-digit code is not specific enough on the HCC model to warrant a payment on that HCC code category. So therefore, if I'm submitting this ICD-10 code, type 2 diabetic, there's no RAF score on the code, and therefore I get no payment on this condition. So some of our EMRs will default the diabetic code to a 2-digit on specificity, and a lot of the 2-digit codes will not RAF. They will only RAF when we're using a 3-digit or more on the specificity or condition of the ICD-10 code here. So as I look through my list of ICD-10 codes related to diabetes and those associated conditions, the more digits I'm adding after the decimal indicates that I'm being more specific on the condition, and I'm gaining additional RAF payments related to those conditions. So we can see here on ICD-10 code E11.610, it RAFs to an HCC code category 18, and I receive a RAF payment of 0.318 on the RAF score. As I bill multiple conditions related to the RAF score or the HCC for that diagnosis code, CMS will only pay on the highest RAF score. So if I go back to that slide where we talked about HCC code 17 being acute, HCC code 18 being chronic, and HCC 19 being unspecific, all of these codes are going to roll up into HCC code 18. So I'm only paid on the highest HCC RAF that's presented through the diagnosis code here. So as I continue down my list, I can see additional interactions. So when I look here at HCC or ICD-10 code E11.21, I see that this code is also mapping to an additional HCC code, and it's also mapping to my HCC code 18. So I'm gaining disease interactions here. So as I complete my ICD code categories and I'm more specific with the digits after the decimal, we can see over in the example, I've increased my RAF score from a 0.318 payment to a 0.535 payment by being more specific on the digits as I'm diagnosing my HCC. Diabetes can cause serious complications, as we know. It could cause heart disease, blindness, kidney failures, lower extremity amputations, all of which should be coded in addition to the ICD-10 code. So in this slide, what we're showing are examples of diabetes codes. So these are all diabetic conditions. And we're showing complications related to those diagnoses and the RAF scores that are potentially billable if you submit the correct ICD-10 codes up to the third digits or more related to these specified conditions so that we warrant a higher HCC category. And of course, related to amputations, we want to remember to document all amputations at least once per year in order to capture that condition and associate that disease interaction with your HCC code of diagnosis of diabetes. Diabetes with ophthalmic manifestations. So a dilated or comprehensive eye exam should be performed by an ophthalmologist or an optometrist shortly after diabetes has been diagnosed, and then repeated annually. So as I look in this sample or this sample slide here, I'm looking at ICD-10 code E11.31 through E11.35 to specify the type of retinopathy. So they want us to be very specific here. So our description in our ICD-10 code should tell us if it's mild non-proliferative, moderate non-proliferative, severe non-proliferative, and we should also include whether or not it's with macular edema in the charting and documentation. In addition to that, you'll see the dashes here. It means that I'm extending my digits on what I'm coding. So do I indicate if it's right eye, and I'm indicating if it's the left eye, if it's bilateral, or if it's unspecified in the eye type? Those should be included through the digits in which you're submitting your documentation. Additionally, on your type 2 diabetes, should it include if it's diabetic cataract? You want to show that information through the ICD-10 code. And any other complications or manifestations such as glaucoma. So this is a range of additional documentation of ICD-10 codes in addition to your diabetic code, which should be included as part of the coding for diabetes. So diabetes with peripheral circulatory manifestations. So again, these are examples of more manifestations and conditions associated with diabetes. This slide is an example of treatment. So in ABI, so if we do the ABI, these are the values. The specified referrals are required when patients are within the ABI values listed here. We're using ICD-10 code E11.51, which is our diabetes type 2 with peripheral angiopathy and gangrene. So we want to specify on the condition that it's including gangrene. So all of these conditions, again, gives us additional specificity in our diagnoses. And I'm just going to bring back my chart here. So the more specific I am within my condition, the more opportunity I have to maximize on my diabetic codes with the HCC code that will wrap to a great degree of specificity. If I'm using a diabetic code within 1 calendar year, and I've identified that diabetic code as an acute or a chronic condition, I'm paid on HCC code 18, which has a higher RAF than it would if I diagnosed an unspecified diagnosis code of HCC code 19. So your RAF payment will be reduced if we're not reassessing the condition in terms of chronic and acute. The unspecified condition that's billed in the current year will stay in the member's chart and submit to CMS as a lower RAF score under the HCC code 19 category. So guidelines are structured. If the type of diabetes is not documented, please mute your phone line. Thank you. So if the type of diabetes is not documented, assign for a code of type 2, assign as many codes from the category E08 through E13 as needed to identify all of the associated conditions that the patient has. For categories E08, E09, E11, and E13, use an additional code to identify if the member is taking insulin. So if there's insulin use, there's a code in ICD-10 code Z79.4. If there's oral drugs, there's an ICD-10 code Z79.84 and Z79.84. So these are all additional categories or diagnosis codes related to your diabetes that will help us in data mining and also help the office to increase their RAF scores in terms of the codes that are being submitted. So the diabetic codes are now combination codes, which include the type of diabetes, the body system affected, and the complications affected with the body system. Before, which are no longer, they used to identify the control status for inadequately controlled, out of control, poorly controlled. Use an additional code for diabetes by type 2 hyperglycemia, example E1065 for type 1. So the greater specificity and the more specific you can be in terms of the patient medications and categories will maximize your greater risk on your RAF scores as we identify and look at the data. So here what I'm displaying on the chart is diabetes and CKD combinations. So earlier in the slide, I mentioned the CKD stage 3 as being an update for 2019 on the HCC model. In 2018, we did not get paid on a stage 3 CKD diagnosis code. For 2019, we now are able to submit stage 3 ICD-10s, and we would receive risk scores and adjustments on our stage 3 CKD value. What we're showing on this slide is we're showing diabetes and CKD diagnoses submitted together. So as you can see here, I'm displaying diabetes, and there's underlying conditions related to diabetes. So here I'm identifying additional note, which is identifying the stage of the chronic kidney disease. On this side of the chart, we're also identifying the stages. We're listing the GFR values. So here are my GFR values and the ICD-10 codes that are associated with the GFR values as it relates to the ranges. In addition to that, we have additional codes listed at the bottom that identifies the dialysis status, the compliance, non-compliance renal dialysis. There are additional codes here. The Z codes if there's kidney transplants involved. So there's a code for every stage of the patient's conditions related to diabetes and CKD as identified here on the chart. So the next slide is diabetes type 1. So again, we're showing the ICD-10 code related to diabetes and the kidney complications. We're showing the type. So here's where we're identifying the type. And we're using additional diagnosis codes to document the so any stages from 1 through 5. And if there's end-stage renal disease complications anywhere related, there's additional codes that we would use there. Additionally, we included the dialysis status, so you can see a Z code there. So this chart will give you the type, the stage, and any additional conditions related to the patient's care. Also, we're including on this slide for ophthalmology, you can see that we're looking at the type stage. If it's left, right eye, unspecified. We're also looking at more specificity on the conditions or stages if their macular edema is present in the eye. So we can use that slide as a reference to ensure that we're capturing all of the conditions to diabetes. Similar to the first slide, this is type 2 diabetes, so it's the same structure. You see there's this type of diabetes. The stage we're listing here, if there's any kidney disease stages, we're able to document those in the conditions. Same with stage 1, left eye, right eye, unspecific, so we can specify those conditions. And then here you'll see that if there's any additional conditions such as glaucoma, there are code ranges there listed for the applications. So what I'm showing on, hello, can we mute our phones? Thank you. So what I'm showing on the next slide is this is an actual chart. So this is a common primary care encounter. What I'm looking at on this file is I have a patient with diabetic type 2 disease. They presented with an A1C, hemoglobin A1C of 8.3. They have stable COPD, and they're oxygen dependent. So we pulled this from an actual chart, and we were able to recode using that chart to identify if we had additional opportunities to capture additional payment on our RAF scores in HCC. So the chart that came into the office was submitted with a COPD diagnosis and my diabetes condition, which was listed here. As we went through the actual chart, and this data here at the top corner, this was received through an encounter file. Looking at the actual documentation in the medical record, we were able to pull here COPD, which RAF of 0.328. The patient was oxygen dependent, so we used the Z9981 to identify that the patient was on oxygen. There was chronic respiratory failure with hypoxia in the chart, so we were able to pick up the J9611, which gave us an additional disease interaction of 0.318. We also identified the E11.65, which is diabetic with hyperglycemia. That was diagnosed in the chart at 0.318. So as we calculated that sample chart, we were able to maximize our risk adjustment score from a 0.446 to a 0.964 for this one patient. So as we go through our reports, we're looking for potential areas in your chart where we can identify and maximize your risk score payments for your individual patients. So this is a good example by looking at A1C, diabetes, COPD, and oxygen to determine if we're able to increase the RAF score on any particular payment. And as you can see here, this is a pretty good example of us maximizing your revenue and your risk adjustment score by including all of the relevant condition categories here. So we documented questions related to the near-miss report and diabetes. So if you can give us just a moment, we are going to gather those questions. So the first question we have, and I'm going to try to read through this. The question we have from the caller is, should we pass the diagnosis of diabetes with neurological manifestations E11.49 as there's no specificity? Provider documented under PE, I'm trying to read through this, manofilament, decreased sensation, tingling, numbness, thinking the provider, so the caller is thinking the provider should have also documented neuropathy, peripheral neuropathy, or being more specific on the neurological complication. And that is actually correct. So in the case of this example, the provider appears, and I'm just going to jump back a few slides here. It appears that the provider is billing a non-complicated HCC or diagnosis codes without any specific conditions. Now, there are certain tests such as the ABI and certain tests, maybe medications, that should be reviewed through your chart. But this is an example of where I would take back to the physician and verify and validate before it goes to the biller to ensure that there are complications documented. So if there's tingling, if there's numbness, I agree with the person that's asking the question. I would also look for some sort of neuropathy or peripheral neuropathy to associate with my unspecified diagnosis. And what that would do is that would now increase my HCC code from diabetic with no complication in HCC code 19, and it would increase my RAF score to an HCC code 18 by being more specific on that condition. Thank you for your question.
I got it, but I haven't had a chance to get it.
If there's any other questions, the line is open, the chat box is open, and we're waiting for any other questions. If you have questions related to the near-miss report, the diabetes report, or any updates to 2019 HCC. So the question is, in the example where the provider billed non-specific, should you file one? And the answer to that question would be yes. So here's an example of the ICD-10 code 11.49. It's your diabetic code with other diabetic neurological complications. And I think actually we want to be, what was that related to?
The first question.
The first one? Okay, yeah. So E11.49 would be a more specific diagnosis code related to that particular documentation. And as you can see, it will map to an HCC code category of 18, which would increase the RAF score.
Hello?
Yes?
Who am I speaking with? It's Nick.
Oh, hi, Nick. This is Michelle Reed. You're live on the Hi.
Oh yeah, I'm at Dr. Lawrence Chell's office, and I was trying to remind them to get on the call so they can learn on the HCC training by Brand New Day.
Oh, okay. Well, we've just concluded the presentation, and we're taking questions related to what we've just. Were you able to participate on the call?
Oh no, I'm doing training on the HEDIS side.
Okay. Well, we have presentation slides available, and if there's any specific offices that need training, please reach out to our provider service team, and we'd be glad to represent this presentation to any physician office that was not able to participate today.
Okay, I have no idea who participated and who didn't, but I know Malcolm Lee and George Chan were going to be on the call.
Okay, thank you. So we have a list of those participants. Thank you, Lawrence.
Okay, thank you so much, Michelle. I'll talk to you soon and meet you soon.
Okay, thank you very much for joining, Lawrence.
Bye.
Oh, Nick. Are there any other questions? Well, I'd like to thank everyone for joining today's presentation. We will leave the line open for questions. Yeah. So please type them in the chat box. Leave the line open for questions. We'll record all the questions and we'll create the frequently asked question list, and we'll distribute that question list along with the presentation and have it posted to the Brand New Day website. Thank you.
Oh.